Hi everyone, my name is Lin Cha Yu, working NICU in the Taipei Medical University Hospital. Today, I'm gonna introduce neonatal nursing. Today, we're gonna learn DR and transitional care, including early bonding, newborn assessment, prophylaxis care to prevent serious disorder, family education, and discharge evaluation. After birth, most full-term infants and early-term infants require normal neonatal routine care to make a successful transition to extrauterine life. Depending on hospital policy, late preterm infants who are older than 35 weeks and well appearing may also only require routine care and may be admitted and cared for in the newborn nursery. Routine management of the healthy newborn will be reviewed here. The assessment of the newborn is discussed in greater detail elsewhere. About the DR care, infants make a successful transition to extrauterine life and require only routine care immediately after birth. Routine DR care includes drying the infant, cleaning and keeping the airway, and providing warmth. Approximately 90% of infants will not require further intervention in the DR. And these infants should be given to their mothers for skin-to-skin contact and the initiation of breastfeeding. So, the initial care after birth, which is first drying the infant, second cleaning and keeping the airway, the third one is providing warmth. For infants who are more likely to require resuscitation, the neonatal resuscitation should be present in the DR to care for the high-risk infant. The identification of high-risk infants and their care is discussed separately. A DR assessment of the neonat's clinical status is quickly performed by addressing the following questions. First, is the infant's GA older than 35 weeks? Second, does the infant have good muscle tone? Third, is the infant breathing or crying? The answers are used to determine whether the infant is admitted to the normal nursery or requires a higher level of care. If yes is the answer to all of these questions, the infant does not require further intervention and should be given to the mother and placed skin to skin to promote infant maternal bonding and early initiation of breastfeeding. If answer is no, then the infant requires further evaluation and intervention, such like oxygen treatment, positive pressure ventilation, chest compressions, use of medications such like epinephrine, and transfer to a higher level of care. The episcopes at 1 and 5 minutes of age provide an accepted, universally used method to assess the status of the newborn infant immediately after birth. A lot of data from a population-based study report that lower episcope of 7, 8, and 9 versus 10 were associated with higher neonatal mortality and morbidity. The episcope should not be used to predict individual neonatal outcome, as it is not an accurate prognostic tool. About the episcope, the following signs are given values of 0, 1, or 2, which are heart rate, respiratory effort, muscle tone, reflex irritability, and color. Scores may be determined using the episcope calculator. The transitional period between intrauterine and extrauterine life is during the first 4 to 6 hours after birth. Physiological changes that can occur during the transitional period, including decreasing PVR with increased blood flow to lungs, lung expansion with clearance of alveolar fluid, and improved oxygenation and closure of the ductus arteriosus. During this period of time, the clinical status of the infant should be assessed every 30 to 60 minutes to ensure further intervention or evaluations beyond routine care are no longer required for successful transition to extrauterine life. The following clinical parameters are monitored beginning in the DR and continuing in the mother or infant's room or nursery. Well, during the transitional period, we should notice that the number one temperature, the normal temperature should be between 36.5 to 37.5 Celsius for an infant. Number two, respiratory rate. The normal breathing rate is 40 to 60 breaths per minute and should be counted over 4 minutes. Tachypnea may be a sign of respiratory or cardiac disease. Apnea may be secondary to exposure to methanol medication, a sign of neurologic impairment or sepsis. Number three, heart rate. The normal heart rate is 120 and 160 beats per minute, but may decrease to 85 to 90 per minute in some term infants during sleep, but that's okay. Heart rates that are too high or too low may be a sign of underlying pathology, such as cardiac disease, sepsis, and metabolic problems. Number four, color. We can observe lips, tongue, and central trunk to know baby if get cyanosis or not. The latest one, tone. Hypotonia may be secondary to exposure to maternal medications or maternal fever. About newborn nursery care. A newborn admitted to the newborn nursery should have an evaluation performed within 24 hours of birth to identify any abnormality that would alter the normal newborn course or identify a medical condition that should be addressed. The assessment of the newborn infant, including review of the maternal, family, and prenatal history. In addition to assessment of the newborn, the following routine procedures and ongoing evaluations are performed after birth to prevent serious disorders. The routine procedures are: number one, eye care to prevent neonatal gonococcal ophthalmia. Number two, administration of vitamin K1 to prevent BKDB. Number three, hepatitis B vaccination. Number four, co-care to prevent infection. Number five, monitoring for jaundice and hypoglycemia. Number six, Taiwan required newborn screening for critical congenital heart disease. Eye care. Erythromycin ophthalmic ointment is recommended to prevent eye infection. It should be applied in each eye within 2 hours of birth. About the administration of vitamin K1, in Taiwan, all neonates receive prophylactic administration of vitamin K1 to prevent vitamin K deficient bleeding. About hepatitis B vaccination, the first dose of the HBV is given within 24 hours of delivery. Infants of virus surface antigen positive mothers should receive HBV in addition to HBIG shortly after birth, preferably within 12 hours of age. If mother virus surface antigen status is unknown at the time of delivery, the neonate should receive HBV within 12 hours of birth while awaiting the results of mother's virus surface antigen. If mother is subsequently found to be virus surface antigen positive, HBIG should be given to the newborn within the first week of life. About newborn screening, we will test number 1, hearing loss. In Taiwan, have early hearing detection that screen hearing in the newborn. Second, the number 2, metabolic and genetic disorder. The screen is obtained by analyzing drops of blood placed on special paper, which is blood spot testing. Blood is collected for an initial screen between 24 and 48 hours of life. Number 3 is critical congenital heart disease. That screening for CCHD using pulse oximeter be added to the uniform panel of newborn screens. Feeding. Infants should be fed early and frequently to avoid hypoglycemia. Breastfeeding is recommended because of its increased benefits for both the infant and the mother compared with the formula feeding. And about formula feeding, should be offered standard 19 to 20 calories per ounce iron content infant formula. They are fed on demand, but the duration between feedings should not exceed 4 hours. About the weight loss, term infants may lose up to 10% of their body weight in the first few days of life, and typically regain their body weight by 10 to 14 days. In a study, infants born vaginally returned to body weight more quickly than those delivered by C-section. For infants born vaginally, 86% achieved body weight by 2 weeks and 95% by 3 weeks. For infants born by C-section, 76% achieved body weight by 2 weeks and 92% by 3 weeks. Glucose screening per AAP guidelines. Glucose monitoring should be performed for newborns with the following risk factors. Number 1, infants of GA under 37 weeks. Number 2, LGA. Number 3, SGA. 4, infants of diabetic mothers. Number 5, infants with a family history of a genetic disorder of hyperglycemia or have physical findings. About hyperbilirubinemia, with a total bilirubin level greater than 25, is associated with an increased risk for BIND. As a result, during birth hospitalization, infants should be routinely assessed every 8 to 12 hours and at discharge for presence of jaundice. Because visual assessment is not accurate for estimating the degree of jaundice. Most institutions include routine bilirubin testing either by transcutaneous bilirubin or total serum bilirubin measurement prior to discharge. About the discharge criteria, these include normal urination and stooling, and stable vital signs, no physical abnormalities requiring continued care, and successful training of the family to provide ongoing care at home. Okay, the latest one is follow-up visit for all infants who are discharged before 48 hours of age. Follow-up assessment is performed within 48 hours and no later than 72 hours after discharge. The follow-up visit should include assessment of the general health of the infant and the infant-mother interaction, parents' well-being, and infant behavior, verification of ongoing health care, and parental education. Okay, these are my neonatal nursery sharing, and hope you guys enjoy it. Thank you for your attention and wish you have a good day.